Yes, in PROpel, what we aimed to do was to use the combination of olaparib and abiraterone in first-line metastatic CRPC. And we'd based that on studies which we'd done previously, a large phase 2 study, where we'd given the combination in late stage, irrespective of homologous recombinant repair mutation status. And we had the same approach with PROpel. The stipulation prior to entry was that the patient had not received any novel hormone agent, although they could have received docetaxel in first diagnosis metastatic hormone-sensitive prostate cancer. The patients were then randomized, but their HRR mutation status was checked by tissue where we had it, or by circulating ctDNA. And we had HRR mutation status checked in about 98% of the patients. And those patients randomized to receive olaparib and abiraterone got the drugs at standard dose. And the control arm was abiraterone versus placebo. Well, an improvement of over 7 months, which is what we saw, is one of the biggest that's ever been recorded in a first-line mCRPC setting. And bear in mind that the improvement was seen against an active agent, abiraterone. It wasn't just a physician's choice placebo, it was an active agent. So that's a big difference. And on that basis, the trial is positive. I think we need to get some longer follow-up with the PROpel study. This is data cutoff 3, which is a timed data cutoff. And at that data cutoff, the trial's positive for its intention to treat. That's its initial pre-planned analysis. That was for radiological progression-free survival as the primary endpoint, and a number of other secondary endpoints, one of which was overall survival. I think what I would like to see is some longer follow-up. When we look to the sub-analysis, that's to say the HRR mutated and non-mutated groups of patients, the control or the natural history in the non-HRR mutated patients is longer than in the HRR mutated. In other words, the biological phenotype, the aggression of those HRR mutated patients is greater. So the event rate in the control arm is much quicker. In the wild type, that's the non-mutated, the events rate in the control arm is much slower, and so they have a longer natural history. What that means is that it takes time for that group of patients' follow-up to mature and their overall survival outcome to mature correspondingly. So I'd like to see longer follow-up, and that's what's going to happen. I can't give you a specific timeline. What I can say is that the patients in PROpel will be followed up for a longer period of time now to see what effect that has over time, and in particular in the wild-type non-HRR mutated patients.